We're going to do a little bit of work in terms of letting you know where we've been as a college and where the profession has been in the last little while. I walked down memory lane. We're then going to talk a little bit about the minister's action plan and picking up on the theme of where the ministry is and where OCFP fits in trying to move things forward. And then we'll talk a little bit about some of the innovations in family practice. And David and I are going to do a little bit of a tag team in moving through that agenda. Again, I'm going to start with a walk down memory lane. And I do this for the very reason that if you don't know where you've been, it's pretty hard to understand where you are and where you're going. So just a reminder of who the Ontario College of Family Physicians really is. We're a chapter of the College of Family Physicians of Canada, and most of our activities relate to the continuing professional development of our 11,000 members, 11,000 members here in Ontario and 26,000 across Canada, including med students and residents and practicing family physicians. So our role is very much anchored in research and education, but we soon recognized that if we weren't active from a policy development position, showing leadership and advocacy on the part of the primary care arena, not much would happen. I wanted you to recognize that in the words of that great Canadian philosopher, Rex Murphy, the healthcare system in Canada has become an absolute icon because it is so imbued with Canadian values. And he stated very clearly that nowhere else do you find those Canadian values more evidently in practice than in the family doctor's clinic room. That patient-physician relationship is the embodiment of our Canadian values. And it's why the primary care system has suddenly become so very popular. This is a picture of me and my brother. I'm the one with the little flowers on top. He had the most beautiful curls in the family. But if you can read, this is a bill from the Hospital for Sick Kids. It was on College Street at that time. In October of '49, Don had been sick. He had a febrile convulsion. He was in hospital for 3 days, and the bill was $6.50. Now, my dad made $14 a week, and he could not pay that bill. And he spent 3 days trying to meet with various relatives, screwing 50 cents here and 50 cents there, until he had enough to get Don out of hospital. Luckily, he was not at readmission because we couldn't afford that. And so my parents' generation really did spend a lot of time and energy creating the educational system, the healthcare system that we all cherish. And it was imbued in a very strong foundation of family medicine. Everybody had a family doctor. And in fact, when we moved to Burlington, in Toronto, I thought I was going to outer suburbia, by the way. The first thing my mother did was find a family doctor. As we moved through the 60s and into the 90s, what we really began to see was a hospital-centric environment that was very much imbued in specialist and specialist care. And the just a GP mantle became part of what we saw in our culture in the healthcare arena. But by the 1990s, we had a number of policy issues that really drove towards a crisis in family medicine. The policies that took place during that time created an absolute crisis in family medicine. And we had 1.5 million people who did not have a family doctor at that point in time. And while our college was really looking towards what we could do in order to improve the situation for our patients, we had a little bit of a messaging problem in that there was many people in the province who believed It was simply a distribution issue. And if our new doctor simply went north, everything would be fine. We were able to identify that we had an absolute shortage and we needed to do something about it. And we were very solution-oriented. We never went to the table whining about the problem. We went to solutions. We also had many, many problems in trying to recruit to family medicine amongst our med students. The deregulation of funding for our med students and residents really encouraged them to go anywhere else but family medicine. And the fact that they were being pushed north and being told if they didn't go there, their fee schedule would be reduced by about 30%, meant that they did go. They went south. Our platinum family physicians, well trained in Ontario, were viewed as amazing physicians by our colleagues in the States. And that may still happen in the very near future. But along came the savior in the system, primary care reform. Now this is a cartoon that was in the Globe and Mail at that time. And if you can read the words, it says, "Through the hoop, Bob, through the hoop." But the ad for the comments that were made in the Globe at that time talked about herding them into groups, putting them on a salary, and working them around the clock. So it was really hard for family medicine to accept the fact that, number one, they needed to go to reformatory and reform, and number two, that the options were being described in such a nasty way. That's one of my members. He crafted that picture as we were beginning to develop some of the alternate payment plans. The Family Health Network was the first in 2000, 2001. And he sent me this picture of himself saying, "You can't pay me enough to do more. And it's only 9 o'clock, and this is what I look like." Now, David is going to move forward with giving you some of the characteristics of why we were able to move mountains, why we were able to get the ministry on board in order to develop a much more robust primary care system, and why family medicine was glad to join that journey. And a lot of the reasons were that we were able, at that point in time, to not only present a blueprint of where we wanted to go, but we were able to demonstrate that internationally, those that were ahead of us, those that had invested in the primary care system in the 90s, when we were ending up in crisis, were actually getting some results. And Dr. Barbara Starfield, who we lost rather recently, was key in getting that message across. So David, if you'd like to take over at this point.
Thank you very much for the invitation to come here. It's terrific to be outside of Toronto and beautiful in here, so thank you. I do want to take you quickly through this. Who knows Barbara Starfield? People know about her work? Some do. You know, she's quite a luminary, recently passed away. In the study of what how health systems work well, and what are the characteristics that make a system work well. And she's really one of the first individuals who researched carefully the notion of what primary care has to offer. And I'm going to show you a little bit of her work because it's had a huge influence on the direction that we've taken in Ontario and elsewhere in Canada and much of the world towards this focus on primary care as a means of improving quality of care, efficiency, and creating a better system for our patients. So she came up with a series of characteristics that she used to create a score for the quality and effectiveness of a primary care system in a country. I'm just going to list here the items, and we've heard about some of these already: ease of access, comprehensiveness and continuity, a strong doctor-patient relationship, a family-centeredness to the system and individual practices, coordinated, integrated care, and an orientation to the community, knowing what the community's needs are and building a system around those needs. And she also talked about cultural competence. Now, with those items in the creation of a scoring system. What you've got here is the score against healthcare expenditures. This is a classic slide that's been presented a number of times. You can see it's fairly old, from 1997, and it looks at a number of countries in the world and the costs, per capita healthcare costs across the bottom. You can see Canada sitting in about the middle, and that places our healthcare score in primary care somewhere in the middle, and our costs in the middle. So there are countries that both do primary care better and cost less, as you can see, and then the United States way off to the right at the bottom with really quite a poor primary care system and an extraordinarily expensive cost per patient. So Canada's in the middle, our usual place, right? This also shows the score against premature mortality rates. And basically, to quickly summarize what this shows, over time, premature mortality has decreased around the world, but those with higher primary care scores have done better consistently. And the areas of improvement of health are listed, are shown on this slide. Again, comparing health outcomes with primary care scores. And you can see that all-cause mortality, life expectancy, infant mortality, and other parameters are all improved with better primary care systems. Jen, you over here? I take my orders from Jen.
Takes a nurse to keep him.
So, summary of all of this is that you get better health outcomes and more equitable access to care with strong primary care. You reduce costs through the reduction in the use of unnecessary tests and referrals and hospitalizations. And you know, the corollary is also interesting. She studied what happens in the States in particular, where there are, and if you look at areas in the country where there are more specialists to population ratio rather than less, you have worse outcomes and higher costs. So not only is primary care good, but an overindulgence in specialty care within the system is probably bad for patients. And I think it goes to show that there's a great deal of wisdom behind some of the decisions now. We've heard about it in the Drummond Report and the action plan to really move the system in a stronger way towards a primary care, integrated primary care approach. And we can see that if there's an expectation that Canada and Ontario in particular will follow along the lines that have been seen elsewhere, and the improvements will be there. So there's good data to support this as the bottom line. Some other information on the impact of a patient-centered approach, which is a fundamental component of how family doctors work with patients and the whole primary care system, oriented around the needs of patients. You can see here that finding common ground, which is working with patients to reach a negotiated agreement on what the next steps ought to be in managing their health, so that the patient and the doctor are both on the same page and both agree with the plan. This results in far fewer tests ordered and far fewer referrals made. Make sense to people? Some I'm sure have seen it in action. And certainly family doctors who are trying to reduce the use of tests, work carefully with their patients and negotiate why we're going in a particular direction, may choose not to investigate immediately, not to refer immediately, but to allow time and initial interventions to play out. And we know that that's a very important cost-saving technique within the system. So it comes down to the individual doctor-patient relationship and this patient-centered approach with patients. So what we're seeing is from some of the crisis that we experienced in the 90s, and are there some folks here who were practicing, there's some family docs who were practicing in the 90s? A rough time for some. Remember clawbacks, hard caps, overall reductions, a real tightening within the system, something that unfortunately is sort of looming again as potentially on the horizon, and that's causing a lot of anxiety again. But we did move away from that, and there were a lot of investments into primary care, and that changed the tenor from one of a sense of crisis to one of greater stability. And it played out in the academic environment, and it has continued actually, so that where we were at a low of 24% of medical students being interested in family medicine, we're now up to roughly 40%, which is a tremendous advance. Now, some would say that with there being now no jobs in orthopedics and tough for general surgeons to find positions, people are moving towards family medicine. So whatever the reason, we actually believe it's because now medical students recognize that a career as a family physician is an outstanding career to take on. And with many supports in the community and models of care that are attractive and more money in the system for primary care, that really is a strong reason behind it. There are many more residency positions in family medicine. We now have the Northern School of Medicine, distributed learning sites in this region of the province, a very strong component of education. And the research networks that are developing as well, all have supported primary care. We've seen the new practice models that we've talked about. These are Jan's F words. And certainly that's the critical change here. To the point that if we look at attached patients or unattached patients, and this is by regions, you can see that maybe the average here places at about 93% of patients are attached to family doctors. So we've come a long way in this regard. And team-based care is gradually becoming the norm. I mean, it's a bit of a stretch to say that we're there yet. We have a long way to go in team-based care. But the recognition that we need to get to team-based care, I think, is there. And we've moved away from the hospital and acute care model to one of prevention and management of chronic disease, which is really where the major inroads are taking place. And team-based care is more than additive. It really dramatically improves the services that we can offer patients. Those of us who are fortunate enough to be working in family health teams, I think have seen that firsthand. It's much better for patients. It's much better for physicians. It allows us to focus more effectively on patient needs with the help of a team and with the independent work of the team, and where we would like to do, which is interdependence, it's gradually developing. We're finding methods of handling particularly chronic disease management much more effectively. This slide looks at a model of interprofessional and community-based care that integrates services internally and externally with a central focus on the patient and the family, but to ensure comprehensiveness, an integrated approach so that there is movement from hospital to home with the use of CCAC and other services that is much more efficient and effective. Supported by evidence-based approaches, and we have in Ontario the advantage of ICES, Health Quality Ontario, and other agencies that are looking at the evidence to support current practices and best practices. So investments in that area have been very, very helpful. Now, the Ontario College developed Vision 2020 last year, which is about raising the bar in family medicine and taking us even further. And the idea behind Vision 2020, and I'll present 6 items here that really support Vision 2020 and what it's intending to bring forward. The vision is that every person have a family doctor. I think that we're, as we said, as we've seen, moving in that direction. We're not quite there yet. And that family doctor has access to an interprofessional team, so that patients receive excellent care and a comprehensive basket of services, avoiding unnecessary visits, reducing hospitalizations, etc. And that access to specialists is provided in a more fluid way. Many of us, I'm sure, many in the room, have some difficulty accessing some specialists. I think this varies considerably within regions in the province. But networks can be put together, and we're seeing it in family health teams where through certain payment models, specialists can work within the offices of family physicians. Patients can take advantage of just-in-time medical advice, continuing medical education for family physicians, and this more fluid access to services overall. Electronic health records, electronic medical records are a further focus of Vision 2020. And the quality networks that we've heard about, we'll talk about a little bit more in a little while. The other piece in Vision 2020 is support for the academic departments of family medicine, which need to be resourced adequately for educational purposes and to produce excellent family physicians. So we were pleased to see after the Vision 2020 was launched, and we've spoken about it in the media and met with government officials about it, that the Minister's Action Plan really talks about some very similar strategies. And so does the Drummond Report. For those who have a chance to read it, as was stated, primary care is really front and center. Really what's being talked about here is that with health promotion and prevention, with integration of public health into primary care, we can have a much stronger system with much better outcomes. And the minister herself is now quite convinced that every person needs to have a family doctor and be associated with a strong primary care system. And primary care includes all of the interprofessional players, nurse practitioners and nurses, and the other health professionals that are working in our family health teams and work in communities, and whose services and offerings can be shared across the community. It's all about, and you've heard this from government before, the right care at the right time, in the right place, using evidence and fluid access. The Excellent Care for All Act, which was released by government and a little while ago, and although mostly focused initially at hospital services, is going to move into primary care for services. The goal being to provide and deliver high quality care within fiscal constraints that we're all facing. It is about value for money, and you've heard that phrase a fair bit. And we've talked about some of these other reports that have come out in support of this. So, Jen mentioned that we've developed a strategic plan at the Ontario College, and I'd just like to go through that quickly with you for the next few years, which has three major points. Realizing the Vision 2020, and we've reframed it a little bit because now that we've heard about the medical home concept, some of you are aware of it, and we'll talk about it a little bit, from the National College, as a model of delivering care that's interprofessional and comprehensive, that really is what we're talking about when we talk about access to a family doctor and a professional team. It's about the medical home, and family health teams in Ontario are an excellent example of a medical home model. And we'll hear more, I think, from Kathy about that in specific terms. The college also is targeting integration of the primary care sector, and really that's the LHIN integration model with some of the details provided earlier. And the notion of engaging every family doctor in both performance improvement for themselves and quality improvement for the work that they do. Specifically, when we look at the medical home, the goal here is that 100% of Ontarians receive the majority of their care in a medical home by 2020. And that in a shorter term, 100% of patients with complex medical disorders have access to a medical home in the next, by 2015. Now that may be a tall order. We've heard that there are 200 diabetic patients, for example, in this LHIN who are looking for a family doctor, and many more with other chronic diseases and complex chronic diseases, I'm certain. However, with Healthcare Connect and with interprofessional models of care, team-based care, I think we can get there. And finally, that 80% of Ontarians will have access to the medical home by 2015. Now let's just talk a bit about what a medical home is we've skirted around this, and let's get to the heart of it. So, are some of you aware of what this medical home model is about? Yes, a number of people have heard of this. And you may be aware that in the United States, this model has been around for some time. It's framed a bit differently. But the College of Family Physicians of Canada decided to maintain some consistency in the use of the terminology around what primary care ought to look like by using a similar term. The patient's medical home is not necessarily a geographic or structural entity. In some cases it can be a virtual entity. But it has a number of pillars that describe what it is and how it functions. And these are the pillars. It's patient-centered, so it focuses on the needs of individual patients and their families. There are family physicians and nurse practitioners who provide the close connection that the patient needs with a primary provider. The care is team-based. It can be within a family health team model, or it can be virtual in a community-based model, where allied health professionals may be attached to CCAC or other organizations, or built in a different way. The hub and spoke model might place, I'm not sure if you would agree, may place more allied health professionals within the family health teams that exist in the region to allow them to fan out community practices. That's going to take some financial investment. We'll see where that sort of model goes. It's based on timely access to care, and we've heard about access this morning. Care is comprehensive across a very broad scope of what's needed in primary care for patients. And where the service isn't immediately available, let's say a practice doesn't offer obstetrical services, there are clear and close connections so that patients can receive the necessary care really through their primary medical home. Continuity is an absolute feature of the medical home, and continuity of care makes it evident. There's good evidence to support that outcomes are better, that there's more efficient and cost-effective care when continuity is built in, and patients are much more satisfied. EMRs and EHRs that are truly integrated, and boy, I'm quite envious of the system that you have that draws data from hospitals right into EMRs in this region. Toronto, I'd say, is way behind you guys in this area and many others. Education and training are important in the medical home because it really serves as the model practice in primary care. So this is where we want our future physicians and other providers of primary care to train. So interprofessional education is going to be important in these medical homes. They need system supports to make them work, and they have built-in evaluative mechanisms around quality to ensure that they're producing the outcomes that ought to be produced. So these are the features that are described in the medical home. If you want more details around what the medical home description is, it's on the CFPC website fairly prominently. I mentioned that family health teams are examples of medical homes as high-performing, high-quality, innovative practices, and innovation is really a feature. The medical home model will move primary care forward. We'll look at new ways of doing things that are more efficient and better for patients, that use new technologies, and that involve the providers in different ways, in more efficient ways. The notion of consultants working within the medical home directly, so that not every patient needs to be referred to a consultant's office to be seen, but there'll be more corridor consultation internally. Will provide us a number of efficiencies. Our target accomplishment, we're back to the strategies now of the OCFP in the next few years, around an integrated primary care sector is similar to what we heard earlier. The LHINs, through potentially primary care councils, supporting the regional hubs, and within these regional hubs, certain centers that provide higher level assessment services and care services around chronic disease is a notion that's being considered. And What we're pretty good at in Ontario College is developing educational programs in primary care that help physicians gain the skills necessary to work in new areas of practice or to elevate their skills so that they can take on what might have been considered secondary levels of care through team-based approaches. And the Center for Excellence in Coaching and Mentoring provides those kinds of supports, whether it's around palliative care or pain management or other areas of practice. These networking collaborative arrangements are very effective. Mental health is probably the best example we have, and probably some of you are involved in the collaborative mental health model in the province, where psychiatrists are available by email and telephone to support family physicians in working with their patients, but don't necessarily see the patients. Yet, skilled family docs are able, with a little bit of support, to manage very complex patients with mental health disorders. The intermediate access centers in primary care around chronic disease could be framed like this as an example of how this might look. These centers being part of the hub, probably sitting within organizations like family health teams, and collaborating with all of those around the circle here, will produce really high-level services for patients that are much more accessible without patients moving around the system, but the system encircling the patient. And we talked a bit about this, and I won't go over it in detail, except there are certain target populations with medical conditions that will be probably most benefited by these integrated models of collaborative services. And here's a list of some of the conditions that patients have that I think we could do a much better job with these new models. When we talk about quality and quality of care, really one of the main target accomplishments is to get family doctors really involved in quality practice. And I'm going to show you in a minute some of the details of what that could look like. Because when we talk about this, at the end of the day, docs are saying, but what are the indicators that you're really talking about? What are we expected to do, and what's going to be measured? Now, there really is growing importance in this whole area of quality and attention to quality in practice. First of all, it's an absolutely necessary way to go to create efficiencies, reduce costs, and create better outcomes. But on a practical level for physicians, it's going to be a considerable measure and tool used in determining remuneration. And once you start talking about money, you get people interested. Now, for those of you who know what's going on with the current agreement with the ministry and OMA, and I'll give you just 1 minute on this one. As you know, the talks broke down, negotiations broke down. Last week, the ministry imposed fee changes to the fee schedule for physicians. This hasn't happened in a long time, where changes have been imposed by government, and it's led to a great deal of rancor that you see in the media. What they initially imposed, many don't take issue with. They've adjusted fees that are very high for certain specialties, for services that no longer take as much time as they used to, and hence shouldn't be paid at the same level. Whether that's ophthalmology or other areas, radiology perhaps. And they cut down they cut down fees for cardiologists and others who order tests that end up benefiting them as well financially. And so there's some question about whether that was the correct model, and this fee adjustment is an attempt to change that model of self-referral for services. That's phase one, and that's what's going on in the last week. But and although some are upset by those changes, I suppose if you're affected financially by those changes, you're quite upset. But the larger group of medical professionals are upset by the process. This notion that government is stepping in and unilaterally deciding what's going to happen on the remuneration side. And for family medicine and primary care, what's planned in the next few years is a little worrisome. I don't know if some of you have seen the details on this. Anybody aware of what the planning is on this one? Just, yeah, no, may wrap and catch me if I'm wrong on any of this stuff. I'm sure you have more detail than I do on it. But in primary care, you know, Jan talked about before that, and we've heard that there's been a lot of investment in primary care in order to get doctors to participate in new models. And these new models are excellent, and we've seen it. We have seen how well they have developed, and the outcomes that they are starting to produce. We're still in the early days of family health teams, interprofessional models of care, team-based care, and we're starting to see the real benefits. There's much more to come, and it's going to be important that this not be dismantled. And the fear is that cutbacks will lead to some dismantling. With what was happening in the 90s, there was tremendous mistrust between the medical profession and government. And Jen showed you that slide of the hoop on the fiery hoop that it was tough to push people through because there was so much mistrust that when government came forward and said, we've got new models of care for you, we're going to pay you differently, you're going to like this. Doctors said there's no way we don't trust government. Government has shown that they cannot be trusted, and that was some of the experience of the 90s. Well, we got well beyond that, and it took a number of years, and Ruth Wilson in the early days of FINS really encouraged doctors to look at these new models of capitation, which I think are much better for patients in the end, and probably quite a bit better for doctors, and work very well in a primary care system that's trying to achieve excellence. And slowly physicians came on board, and then it became apparent that that was really the only way to practice for a number of reasons, one of which became remuneration. Physicians were better remunerated in their systems, but it took that kind of incentive to really bring it to the fore. And then what happened last week came as a big shock, that the relationship of trust between government and the profession was suddenly sort of brought to a halt. And that's what's got people really nervous. So when you read about this and hear about it in the media, it's about this nervousness of a bit of PTSD for docs who lived through the 90s, this reemergence of a fear of what's this relationship that was so strong, collaborative, and effective going to look like in the next few years as government has to pull back and deal with budget deficits. So what's called for in family medicine is a reduction in some of the payment fees within these models around comprehensive care and a reorientation towards pay for performance. Pay for performance is about target accomplishments and quality that will lead to funding and more funding. So family docs will lose funding in certain areas of practice for certain activities or practice parameters that have not delivered on the quality goods, and those monies will be reinvested towards reimbursement for quality. So, I'm going to skip ahead to a couple of slides and then we're going to wrap up here. You won't be able to read this, so I'm going to read out some of this too. When I talk about quality, the question is, what do we mean in family medicine and primary care by quality? And some of you probably have worked on quality indicators, well, far more than I have. Jan has done a lot of work in a collaborative relationship with Ministry, CIHI, OMA, Health Quality Ontario, and Western and Matt,
Queens.
And Queens. Developing quality indicators that can be used to measure the quality of our practices. Most indicators for now, as you start to look at these, you'll find are process related and not so much outcome related. Outcome being better health. We tend to start with process measures, recognizing that good process tends to lead to good clinical outcomes. And process measures are a little easier to actually observe and measure. So they're under a number of categories. Patient-centered category, and I'll just read these quickly for you, for those who can't see this. The practice team encourages patient feedback and suggestions. The practice team respects patients' rights to complain. Patients are provided with enough information to make informed decisions about their care. Under the equity category, new patients are accepted into practice without discrimination. The clinical team identifies and provides additional services for patients with special needs. Under the timely and accessible care categories, patients can reach the practice by telephone, email, or other electronic means. Patients can book appropriate appointments. Investigations and referrals occur in a timely manner. Clinical team provides 24-hour care, 7 days a week, and it responds to emergencies and urgent situations. Under safety, drugs that are available in the practice are appropriate, controlled, secure, maintained, and there's a strong prescription management program in place. Under the effective clinical practice, so this is a little bit more around practice-specific clinical outcomes. The indicators are around smoking cessation, immunizations, screening. You see a few screening areas here around colon, cervical, and breast cancer. Around mental health outcomes and management, around diabetes, hypertension, and asthma. In the integration and continuous one on efficiency at the top there, managing tests and reports efficiently. Under integration and continuity of care, continuity for those with high complex needs, and out-of-office care. And then finally, is the last section, appropriateness of practice resources. And this is about how you run your practice with human resource policies, team functioning, a balance in home life for practice members, the buy-in and commitment to CQI, and risk management. So, that's where things are at right now in terms of what are we looking at regarding quality. But I think it's important to pay attention to these things, and newer models of practice, family health teams, and other group practice model arrangements are starting to focus on many of these things. But it looks like these are the kinds of indicators that are going to be used to determine performance in primary care practices, and they will be important as we move forward. And I think with that, I know Jen has a couple of other slides, but I think I'll stop at this point and leave a few minutes for questions.
Okay, thank you very much, you two. And would you like to say a few more words, Jen, before we go to some questions? I'll start. Oh, we have a question here. Great.
I think that was a great talk. It's very timely. I'm wondering if either of you could comment about some of the controversies in this model. That some suggest that the medical home model mimics the managed care or gatekeeper model that's employed by HMOs in the United States as well. This seems like it's taking the family doc again back at the hierarchical model and putting them centered again in these primary care delivery models. I thought we were going away from that in delivering primary care. As well, there's been criticisms in the United States about this model, both from emergency physicians, psychologists, and optometrists, as they see it as barriers to accessing quality, efficient care. And there will be incurred extra costs, which would include IT, extra IT, and extra staff to deliver the model that you're talking about.
So down in the States, there's only 12% of the practicing physicians that are family physicians, and the model in the States is very much one of families having their own specialist in obstetrician, obstetrics, in internal medicine, in cardiology, and the like. It's a very expensive and a very fragmented system in the States. So the college, the Academy of Family Physicians in the States and primary care providers like pediatricians and the like are really struggling to move forward with a model that much more mimics what we see across Canada in the strength of family medicine. I think when you're talking about a family medicine focused practice, it is the reality in most of Canada. I think the model is very strong in saying that every person needs to have someone, preferably a family doctor and a nurse practitioner, working in a synergistic type of model. Not one, not the other, but when we work together, we end up with 1 + 1 = 3, surrounded by a really strong team. And that team consists of many disciplines depending on what the person requires. And in actual fact, if you look back at history, we oftentimes had that kind of model in place across Canada, but we relied upon outpatient departments within our local hospitals, and they were decimated during the 1990s, and family physicians were left with the most complex of patients with nothing left in the communities but private sector organizations that many of our patients couldn't access. And I think what we're trying to do with our family health team models, which are a good example of what we're talking about in the medical home, is recreate a system in which people actually have access to the care delivery providers that they require. And if we're requiring access to optometrists as an example, we're seeing models in which family physicians and optometrists have been able to work really well together in a private sector and a family practice arena to overcome the difficulties that practices have in getting the patients in to see an ophthalmologist who've been paid to do a whole bunch of cataracts and can't deliver the medical care that many of our patients do require. We're seeing wonderful models in which dietitians who are working in the private sector are running groups inside family practices and using insurance from some of the patients to serve a larger population who don't have insurance, who sit in groups. And so I think the model has wonderful opportunities to make great use of what's in the community, to take our mental health and addiction workers where our patients are very uncomfortable going through the wall that says alcohol and drug rehab center into our practices. I think there's just unbelievable opportunities to use the framework of the medical home to create what people really need, good access to health care.
Well, I would agree, but I think it exists already. I think it's a CHC. I think it's a nurse practitioner-led clinic. It seems like we're just, again, reinventing the wheel, throwing resources into new thoughts because we can't cope with the existence of what exists in 2012
I think
today.
there's a wonderful place for our CHCs. They have been extraordinary in identifying the really vulnerable patients who do not have that OHIP coverage and really need much more in the way of social care than they may even need medical care. But the truth of the matter is, in Ontario, we have 80% of our patients that are still being delivered the majority of their care in family practices. And we need those family practices to be as strong as they possibly can be.